There are countries who have identical population health indicators measured by life expectancy, infant mortality, that have wildly different numbers of doctors per capita. So if that's the case, the only conclusion you can come to is that whatever is causing the good health status, the number of doctors doesn't explain very much of the variation. It only explains some of the variation at the very right end of the scale in very poor countries. So when you say, do we have a shortage of doctors, the only way you can say definitively yes is if you're saying, if we continue to do things exactly the way we do them now, and organize or not the way we do now, with the same division of labor we have now, then we have a shortage of doctors, probably. But if you think that the purpose of having physicians, nurses, and anybody else in the healthcare system is to produce better health, then the solution is very unlikely to be more personnel, particularly in a country like ours, which already has fairly abundant numbers. Now, I could make the same case about nursing. You know, we have even dire shortages of nursing projected, up to 150,000 short. Somebody just broke a plate back there, so if there's a nurse in the house, go and check it out. But there are two interesting realities there. One is that we deliberately, by policy, by moving to degree entry, and I'm not saying this was a bad thing, I'm just saying when we moved to degree entry, we deliberately reduced the number of nurses that were going to come into the system, because there's no way you can make a transition from a 2-year diploma to a 4-year degree very quickly and turn out the same number of people. Secondly, every study shows that nurses spend approximately 50% of their time doing direct nursing care. And they also report that they are very frustrated with all the non-nursing duties they have to do. So if you could increase the proportion of time that nurses spend doing professional nursing for which they are educated to 70% from 50%, you've increased the supply by 40% without adding one human being. So you might want to think about whether or not the approach that we've taken, that is to ramp up nursing enrollments, is actually solving the root problem. And the root problem is not only that it's a little inefficient, but it's also not very satisfying. If I would read the press releases from registered nurses associations and nursing unions, and they all said, we are deliriously happy, thank you very much, we love our work and we're going to work till we're 90. I would say, fine, I don't mind that only 50% of your time is spent nursing, but they're all miserable according to their official press releases and their public comportment, so maybe they would be less miserable if they agreed to another look at this. So this is what we've learned. And some of the things, people have said Canada doesn't know how to innovate. Well, I don't think that's true. I think we innovate very well. We just innovate once and then stop there. We don't actually spread it. That's the big problem. And it does seem that change is harder in Canada than a lot of other countries around the world, and we can talk a little bit about that if you wish later. I haven't met anyone who said the status quo is fine. The public says it isn't. Providers say it isn't. Managers say it isn't. Governments say it's not fine. So I think, and I think the second last bullet is my central point. You know, people hate change. It doesn't really matter what the magnitude of it is. A little change is just as disruptive to their psyche and well-being and causes the same degree of agitation as big change. And so, you know, you wonder, why do we continue to pursue small incremental change when the pain is just as great? So I think it is the right time for transformation, because all of those things we talked about earlier that we've tried haven't actually achieved the transformation. And before we get any further into this, I have to talk about what I think is the elephant in the room, and I'll put in a plug here. The Health Council of Canada, on which I sit, is producing what I think will be Canada's first ever value for money report later this year, just try to get a handle on where all this money is going and what we get for it. But I think it is important to say this, that it is no longer how much we spend, but what value we get from it. Because we have tried the shoveling cash approach for a decade now, and the system, while it may be better in some aspects, still has a long way to go. And the reality is we're not alone. When you get into the advanced countries or the industrialized countries of the world with high incomes, everybody suffers from the same problem. That is, it's hard to extract greater health value from additional spending, no matter how you ramp it up. So we need to change about a couple of things. First of all, we need to scrutinize value for money a little more carefully, which we have notoriously never done in Canada. And we also have to pay attention to the opportunity cost. It's not just that we spend a lot of money on health care that may not produce much health benefit, even if it produces better access and comfort and reassurance, but if we had spent the money elsewhere, would we actually achieve better health gain? And when you listen to the presentations from earlier today, and particularly Dr. Folletti's, maybe we need to spend considerable money elsewhere so the healthcare system doesn't have to attempt with some futility looking after problems that have a 50-year developmental cycle. So this is just illustrates the point about life expectancy versus spending. And this is a flattering graph, actually, for the high-end countries, because you could just as easily bend that curve down, starting about halfway over to the right. So on the vertical axis, you have life expectancy, and on the horizontal axis, you have per capita healthcare spending. And as you can see, beyond about $1,000 per capita, there's no relationship. And if you go over to the far end with the United States, it's actually negative, because the United States spends still 1.5 times as much as anybody else and gets very bad health outcomes. It's the bottom of the barrel on the rich countries on just about every health indicator. So this is a curve that as citizens we need to pay attention to. So if we're not getting added health status, or very much added health status for the last $4,000 per capita of health spending, what are we getting? Well, we're getting stuff, but we need to find out what it is and if it's worth it to us. You know, maybe we have become a little too dependent. So there are some other troubling paradoxes here about quality and safety. And all of these things are true. You know, I don't think we have a shortage of brains in the system and talent and commitment. I think we have never had such an educated and technically sophisticated workforce, and we haven't had technology like this ever before in human history. Yet we have very many avoidable errors in the healthcare system. It's literally anywhere up to 9,000 avoidable deaths in hospital a year, and probably an equal or greater number in the community. These are avoidable deaths. These aren't just deaths that happen because of things that you can't foresee. And we've talked a lot about primary health care today. Primary health care all over North America is essentially a coin toss. That is, you have about a 50% to 60% chance of getting the recommended guideline evidence-based care for any serious chronic disease by going through the primary care system that is full of highly motivated and technologically sophisticated people. So just to give you the most famous study, which is the American one, LHIN, she looked at 400 conditions, but these are 5 prominent ones. And it was essentially a chart-based review all over the United States that looked at what people got in relation to their conditions. So if you look at the alcohol dependency, what are the chances of you getting both assessed for alcohol dependency and counseling, but 1 in 10 chance that you were going to get that in primary care, which again, when you think about Dr. Folletti's odyssey and the, you know, what people ask about, obviously they weren't asking this. Even for diabetes, which is probably the best studied, most highly chronicled, most quality improved chronic disease, half the time people get the recommended care according to guidelines, and it goes on up and so on and so forth. But even heart disease, which is life-threatening, and you'd think that people would pay attention, and that the typical informed layperson reading the newspaper, if you asked them, you had to play doctor for a day, what would you do post-MI? Well, I think there's aspirin, beta blockers, and something else, right? So, you know, you could probably get 2/3 right by random chance. So the fact that people aren't getting this care suggests a different kind of problem. It's not knowledge. It's how do you communicate what people need to do, and why or why not do people adhere to recommended therapies. So this is what we've learned. We've learned that having more, meaning more resources, more dollars, etc., may actually cause as many problems as having not enough. And if you ask regional health authority board members across the country, when were the prospects for real transformation the best, they would tell you the mid-90s, because, as Rutherford said in his lab in 1913, gentlemen, we're out of money, now we have to think. Because we were out of money in the mid-90s, but we haven't been out of money since. We've got more money than we ever had before, and as I will talk about a bit later, there's a guarantee that there will be more money because of what the federal government has put on the table and signaled well in advance. So, as someone else mentioned earlier, it's not the doing that's the problem, it's the thinking creatively. No doubt the healthcare workers are working harder than they used to, and they're burning out, and they're frustrated, and they are running faster to try to catch up. But it's not going to help much. It's just going to burn them out, and it isn't actually getting the job done, because this isn't an activity problem. This is an ingenuity problem. We also make the easy mistake of assuming that correlation is cause. So if you ask the medical associations, So, what about healthcare spending? They will say, well, look, life expectancy has been rising 2 years per decade ever since the 80s. So this is a good thing, and we've also been spending more money on healthcare. So therefore, spending more money on healthcare is causing the life expectancy increase. It's a fallacious argument, but it's an easy one to make, and it's an easy mistake, the correlation for the causation. So we've got to think about that. And of course, we are Canadians. So we do everything incrementally.